Hello, everyone, and welcome to one more episode of MetaCast, the podcast of the Meta-Analyses Academy. I am thrilled today to welcome to the stage Dr. Alice Gallo, Associate Program Director, Internal Medicine Program at the Mayo Clinic in Rochester, Minnesota, a leader in the field of mentorship and medical education. So I'm really grateful to have you joining us here today, Alice. Thank you so much for participating.
Thank you for having me. I'm the one who's grateful, and I'm so excited that I got to see you in person for the first time.
Yeah, no, we've interacted many different times over the years on social media and through common friends, and I'm really glad to meet you in person here today and to record this session. And I'm sure it's going to be very educational for our listeners as well. Just before I ask Alice to introduce herself, I want to give a disclaimer about the Meta-Analyses Academy, this session, the MetaCast. This is in no way affiliated with Brigham and Women's Hospital, Mayo Clinic, the institutions where we work. The opinions here are our own. If you're tuning in for the first time in MetaCast and this podcast, I discuss success stories of doctors, medical students, trainees, residents who've done extraordinarily well in their career so far. And I can think of no better example than Dr. Gallo here with me. So Alice, could you introduce yourself?
Yes.
Please tell us a little bit about your journey.
You're very kind, first of all. So I'm Alice. I was born and raised in Porto Alegre, Rio Grande do Sul. For those of you who are not Brazilians, all the way south Brazil. We do have 4 seasons, so that explains a lot about some of my choices I've made after I left. I went to medical school at PUC do Rio Grande do Sul. Don't know how to say this in English, actually. And I did residency at Hospital Nossa Senhora da Conceição, also in Porto Alegre. And then while I was doing residency, I knew I wanted to do critical care. And in Brazil, critical care is not combined like it's here, right? So it's a straight critical care subspecialty. And I thought I wanted to be a trialist because, of course, why not? So then I came to the U.S., a couple of institutions that were very strong in critical care trials, and met a bunch of people. And my goal was to go back home with mentors, so when I went back to residency, I would hit the ground running in terms of enrolling my institution in clinical trials and things like that.
Right.
And then when I was in Miami, I met Dr. Lynch's, and for those of you who've been in Miami, I think he left in 2015, I want to say. 2016.
Yeah, I was there until 2016. I think he was there still. So right around that time.
Yeah, so around that time. He was also an APD there. And he was like, why don't you just come? Just do the steps and come. And I'm like, that sounds great. And this was August of 2008. Sorry, I'm aging myself. But 2008. And I applied to the next match cycle. So I did 1, 2, 3 at the time. No, 1, 2, and CS at the time in about 9 months. Don't recommend. 10 out of 10 do not recommend. But it worked for me. And then since I knew him from before, I applied there and ended up matching there. At that time, I think we were still allowed to kind of have a gentleman's agreement.
A kind of pre-match.
Yeah, kind of a pre-match.
Yeah, I remember those days. I matched there in 2012, right after you left, I think. So
I left in 2012, exactly.
Yeah.
Oh, yeah. Because you started in July of 2012, right?
No, July 2013. I applied 2012.
Okay.
Yeah. So you had recently left.
Yeah. And then I matched there, and
the rest is history.
The rest is history, yes.
So we're going to talk a lot about our journeys and your journey specifically in training in the United States. I'm going to ask you a lot of questions. People are going to be curious about your role as Associate Program Director. But I guess we can start in chronological order as you've introduced yourself in that way. So what was residency like in Miami? You know, we share that in common. We had that experience of going through the wards at Jackson Memorial Hospital, doing the MICU there. I have great memories of that program. What was your experience like training in Miami?
I really love that program. Love the program. I love my friends I made there. I have friends who to me are family, and I would give them an organ. And I feel like the the wards of Jackson Memorial forges in fire a little bit, but in the excellent way. You have to be resourceful. You have to be efficient. When I was there, we still had paper charts at Jackson.
That ended my intern year, 2013. You know, I used to call the nurse somewhere else to give an order, and I had to spell my name Nascimento Cardoso for like a million times during my intern year. Then they went to EMR, electronic medical records.
So, but when I was there, so the VA had the VA system.
CPRS.
Jackson had paper charts. And the University of Miami Hospital had this very
Meditech.
bizarre thing that looked like an old video game.
Yeah.
Yes, looked like original Pac-Man.
Yeah, that was my intern year.
Yeah.
I remember that.
And then I think if you did clinic at UMH, you had a Epic already, but it was a different Epic.
Yeah, something like view only.
Exactly.
Very weird system at the time.
Very weird system. But
We're speaking this. I just want to give a little bit of context. So the program in Miami, a lot of you guys will be interested in that program because it's a strong academic program. And one of the things that we're talking about is just the diversity of the training that we get there. So we just mentioned 3 hospitals. There's Jackson Memorial, which is one of the largest county hospitals in the country. It's really where you get to go to the trenches for internal medicine, really advanced pathology. Patients come from Central and South America with, infectious diseases, natural history just goes very far before these patients are diagnosed. And then you have the private hospital, University of Miami Hospital, and then the VA, which is a Veterans Hospital. Yeah. So it's really diverse.
Yeah, it was awesome. That part was awesome too. And Jackson Memorial also, I remember fondly, the patients were so thankful for any attention and any explanation you gave them. They were just it was very, they were very thankful. And I have a very special place in my heart for the veterans. I really appreciate them. So I also had a very special place in my heart for the VA.
Yeah.
My clinic was a Jackson clinic.
That's tough.
For those of you applying to Miami, I don't know if things are still this way, but when it comes time to choose your clinic, if you can still choose your clinic.
I got that same advice.
But I did not know that.
Advice. I picked the VA clinic.
Yes, so pick the VA clinic if you can pick one of them.
Yeah. This is really golden advice for all of you who are going to apply for internal medicine and match in Miami, okay? Yeah. This is going to be a game changer for your residency.
And again, my glass is always half full. So my friends who had clinic at the VA would be like, "Oh, Alice, you're still in clinic." I'm like, "I'm learning more. It's okay. I'm learning extra skills of efficiency. I'm learning extra skills of how to write meaningful notes that are super short and sweet, Yeah. So that was the way that I convinced myself that Jackson Clinic was the best for me.
Yeah.
And the patients, in my opinion, the patients were great. So very fond memories of the wards, very fond memories of having to walk around with the charts. And then
the people too.
People amazing. The nurses took great care of me. They were amazing to me. I always knew I wanted to do critical care, obviously. So I had this thing, don't do this. I don't recommend. I already did it and it's done. But I would find friends who wanted to go into rheumatology or endocrinology or things like that. And I would be like, you do 2 of my clinics and I will take 1 of your night shifts in a weekend that
was a good deal for them.
I think it was a great deal for me. So I did a lot of that. But we can't say that a lot.
Yeah, I think it's a long time ago. I think it's okay. No one's going to get in trouble.
No one's going to get in trouble.
Yeah. No, my time. Yeah, 12 years, long time ago. Jackson was great for me. I'm going to, just on this, a quick comment on this before we move on. When I applied for internal medicine residency, I applied straight out of medical school, unlike you who did residency first. And I was very naive. It wasn't back then. And we talk about back then like it's 50 years ago, but this is just 10 years ago. But you didn't have the opportunity to send an Instagram direct message to someone like you and other of our friends, and ask questions about applications. So I was very naive. I read the ECFMG information booklet. I did the steps. I did observers in Miami in the Harrington program. So that was my application. And when I interviewed, I was really between 3 places. Mm-hmm. 1 program in Miami and then 2 programs in the Northeast. Great programs, sort of like at the same academic level as Jackson. As Miami. And and then I got that offer.
Yeah.
I don't think I ever mentioned this in this forum. So if I did,
I love it.
I'm sorry if I'm repetitive, but you may not know this, but I interviewed late in Miami. I interviewed like in January.
Oh, wow.
And again, I didn't know about the pre-match and the advantages of interviewing early at that time. So I didn't know this, but I don't think there were many spots left when I interviewed. But then when I went back to Brazil, I interviewed in these three places, went back to Brazil. In the last day, you could change the rank order list. My phone rang at home. It was Barbara.
Yes. Barbara.
And then
An
she's like,
institution.
yes, Barbara helped.
love her.
She was the administrative arm of the program at the time. And Barbara said, Randerson, someone gave up on their position. Do you want it? And I'm like, of course I want it. So I took the last pre-match at the time. And again, this is a long time ago, so I don't think anyone's getting in trouble for this. So now they have separate ranking systems for the Harrington program.
Yes.
So I got the last position, and I'm really grateful for it because it was such a great place to train, a great place to transition from South America. And we all learned Spanish there. Habla español too, right?
You know, it's funny. I lived many lives. I actually lived in Spain with my parents when I was 12 years old.
So you knew
I
Spanish.
lived many lives already, and it was very funny because I lived in Spain. So my Spanish accent is español, not.
People like thought you were a native Spaniard.
And my first patient at Jackson Clinic looks at me like, Doctora, quiero alguien que hable cubano.
Wow.
And I'm like, Señor, estoy hablando español perfectamente. And he goes like, no,
Que habla cubano.
quiero alguien que hable cubano. But like very nicely, but it was like, wait, but like I'm speaking Spanish to you. Like I lived that whole year.
The first thing I learned in Miami, going to take those admissions in the ER in Spanish was habla despacio, por favor. So because of the Portuguese, I could understand most of it. But then it would work with everyone. But with the Cubans, they would just repeat the same thing as fast as they said it the first time. Habla despacio, por favor. Okay. And then they would just go again fast, So I still didn't understand anything they said. It was tough. I kept imagining my American friends who didn't speak any Spanish and had to use a translator for like 50% of the admissions. It was tough. All right. So Miami was great. But before I move on,
Miami?
I love Miami. I was going to ask that because you were the only person I know that didn't like have a great time in Miami City. Why not?
It's too hot. I don't know. It's too hot. I miss the seasons. That's number one. Every 48 hours I had off, I would go to Disney. So I love Disney. I'm like totally, it was like my favorite place on earth after an ICU.
Oh.
My home first, then an ICU, and then Disney. And it's just like, for example, you had a day off, and then you wanted to go to the beach. It was great, but then you had to leave your house at 7 a.m. because otherwise MacArthur was like impossible, and you wouldn't find a parking spot. It was just too much. And I'm not a big party girl. I've always been like more of like a dinner party at my house for like few people. So I was always in bed when people were going out. I do miss walking to the arena that is not called the American Airlines Arena anymore.
Really?
No, they've changed the name. I'm a big basketball fan.
I was there the 2 years the Heat won. And
Yes.
back. I was there as a resident. I think it was 14 and 15 or 13 and 14. Something.
And I was there the year LeBron arrived. So I was there for their first victory, LeBron, Wade, and Bosch.
I saw him at Jackson once. They used to visit the patients there.
And I used to run around the arena, and I saw them multiple times, coming into training, and they would wave. They were very kind, all of them. And the first parade, when they won, the three of them, I was post-call from Jackson Wards as a senior. I went to my apartment, changed, comfortable clothes, and went to the parade. It was super cool. I missed that part, but it was too hot for me. Too hot.
I'm from a place in Brazil where it's always, we just have 2 seasons, the really hot and the even hotter season.
That's Miami.
Yeah, exactly right. I felt right at home. The culture was the same. I'm not a party person either, but the people just made it worth it, and the city, I loved it. I loved my time in Miami.
I loved my time too. I loved
city.
residency. It's just and again, I loved going to the movies, for example. Love like the little place in Coral Gables. I love that place. Forgot the name now, but love that place. But again, we had to plan an hour in advance to leave the house. To
Not like that in Rochester?
Oh, Rochester, like if you drove more than 10 minutes, you left town. It's gorgeous.
You're being like a cornfield or something.
Yes, middle of the cornfield. This is a beautiful cornfield. Like today, I'm gonna tell your listeners about this. So today I was like, okay, I need 15 minutes. I looked on the map. I'm like, I need 15 minutes. And it took 25 minutes to get here. I'm like, wait a minute, what traffic? What is this? In Roch, if you have like 10 cars at a traffic light, you're like, something happened. Something happened. Like, what is happening? Where's the police car?
You mentioned 15 minutes turned into 25 because of traffic. Yeah. Once, I remember the story. Once I interviewed at UCLA for fellowship. And for the stupidest thing, I decided to stay close to the airport because it was cheaper.
Yeah.
And the next day I had interview. And then it was the scariest thing ever. It was like I started off the journey with like, I don't know, 25 minutes. It turned into like an hour and 55 along the way. And it wasn't like accident. It was just like traffic.
Yeah.
I'm never going back there. Never. California, Los Angeles, no.
Yeah. And it's very interesting that we're talking about this. And then I realized that I liked smaller cities to the point that when I applied for fellowship, did not apply anywhere in New York.
Yeah.
I did apply here in Boston because I love Boston. I love how classy Boston is
really
to my eyes. I'm even like, wow.
Yeah, you look fancy.
I just love how classy Boston is. And but I didn't apply in New York, for example. And again, I know a lot of people love New York, but I just didn't see myself living there again,
totally.
Like in a big city again. And I'm a big fan of my cornfield. You know, like I love Minnesota.
So yeah, on this topic of cities, let's just jump right into Minnesota. What's it like living in Rochester? And of course, I want to talk a lot about the Mayo Clinic too and your experience as APD, but let's just make this contrast. What's it like living in a small town where you have probably one of the best, if not the best academic center in the world in medicine, and you can practice really top-notch medical care?
So there are three things that keep me in Rochester.
One, weather.
I love the snow. I think the snow is very elegant. Yes, but that was not what I was going to say. It's not as hot as Miami. Number one. No, but seriously, the people is like what we were saying. Yes, the warmth of the people we met in Miami. There is just the same warmth, but in a very simple way.
Not loud way.
Not loud way. And not attached to monetary values. How about that?
Yeah, I love that.
Yeah.
The Midwest are just nice.
Exactly. Just truly kind people. One of my best friends is actually originally from Connecticut, and he was a firefighter, and he decided to go to medical school. And again, he went there for residency, met his wife in residency, and stayed there for fellowship. And he's a Mayo lifer, like he says. And it was just like, it was my first week of fellowship. He was I should have said that. Attendings at Mayo Clinic are called consultants. And
like the British.
I'll explain why.
Okay.
Because the Mayo brothers always said that the trainees were the primary physician, and whoever was there to teach them they were consulting them. So I think that's pretty cute.
That's amazing.
I was on call with him for my first night of fellowship at 3 a.m. We start talking, and seriously, like both of us are like, I'm like, you're an only child, right? He's like, yeah, you're an only child, and we're friends forever. And he's like, my little sister, and he's like, my brother, you know. It's just like the people. And
he was a consultant?
Yeah. Yeah. And he was already like, I think it was his 8th or 10th year on staff already. And we hang out. And it's like, hey, bought good meat, because he knows I like good beef. He's like, I bought good beef. Do you want to come over? And it's like this. And it's simple. It's very simple. So the people are simple, and I like in a good way. And I love the fact that I drive 3 minutes from my garage door to the hospital garage door at 5:30 in the morning. I think that's pretty spectacular. And I really love the Mayo Clinic model of care. The needs of the patient come first, and they truly do. The care I'm allowed to give patients at Mayo Clinic. It's very hard to even explain, put into words.
Yeah.
I remember one time I had a patient in my pulmonary clinic, and because of insurance in the United States, she owed a little bit to her insurance, and the Mayo Clinic office emailed me, and they were like, does her appointment need to be scheduled like now, or can we wait until she pays? And I'm like, it needs to be now. Like, she doesn't have like 3 months to wait for this. No problem. No questions were asked. Her appointment was scheduled.
Wow.
And this, again, I'm a big history of medicine fan. I love it. I'm a very big nerd, actually, to be honest with you. I'm a very proud nerd.
I didn't know that.
I'm a very proud nerd. And the Mayo brothers, actually, the Mayo dad. So W.W. Mayo was the dad. He partnered with the Sisters of Assisi Heights, and they had this bag that they had a bunch of cash there that people who could pay the Mayo Clinic at that time, 1850, I believe, 1853, 1850 something. If they gave extra money, they put in this bag. And then let's say someone could not pay, then the sisters will come like at night or when the patient was out for a test or something and would drop like a few coins and few dollars. So then when someone came to bill, they had money to pay. And that's still what we do. Like, if the patient needs something, we're gonna make it happen.
Yeah, I'm a huge fan of the culture. I spent 1 month at Mayo, Florida, when I was a resident in Miami, as a second or third year resident, and I was just blown away by the culture, by the needs of the patient comes first mentality, by the need for excellence. Like, if you're not excellent there, if you don't do your very best, and you just feel uncomfortable. Like you wouldn't
fit in.
Yeah, you don't fit in. Exactly. None of this, why you're calling this consult.
No.
It's amazing. It's
and
amazing.
the other day, actually, it's funny you say that for consult. The other day, I called for a consult, and I know they were very busy, but the fellow called a brand new intern and said, I'm not going to see this patient. I'm not going to write a note. And I'm like, So I called her, and I'm like, are you new at Mayo? And she's like, oh, why do you ask? I'm like, yeah, because here we help each other. So I'm fine if you don't want to see the patient, but you need to write a note. And remember when you were an intern, don't forget that. And she later on came and talked to me, and she's like, I really appreciate you calling me out. And I'm like, and I thought it was good feedback to give. And we both were very collegial, but again, the needs of the patient come first, and help will be given at Mayo for those who ask.
Yeah, and I think that's how you maintain that culture. It's, you have to have an open communication and say, these are the expectations. You have to live by this. Yeah.
But she's like, yeah, I am. Like, I just started fellowship. I'm like, okay, yeah. Good.
This is not New York. It's not Boston.
I don't even know where she's from, but I was like, hey, listen.
Yeah.
That's what we do here. So, yeah.
No, that's great. And then let's talk about that transition. When you finished residency in Miami, you applied, I suppose, broadly, and no, you just really.
So I have a very interesting family history. My husband started surgery in Miami, and he.
So when you say started, I suppose he didn't finish.
He did not finish. He finished intern year, and he was still miserable. And he's like, can you help me write an application? I'm like, I thought he was going to do anesthesia because he at least could use that intern year. Yeah. He's like, nope, I want to do internal medicine.
Wow.
He had been to Mayo when he was in medical school for a clerkship.
Okay.
Because he's from Porto Alegre as well, and his medical school Fundação has VSLO. So it's one of the schools that Mayo would take visiting medical students for clerkships. And he had done a vascular surgery rotation because that's what he wanted to do. So he did his surgical clerkship at Mayo Clinic. And so he had his clerkship grade. He had gotten honors. He had letters from them. And when he went to his interview for his surprise, the person who interviewed him is one of our fantastic primary care physicians who had done 3 years of anesthesiology and hated it, and switched to internal medicine, primary care. And he's like,
So the connection.
He's like, I think they get me. I think they get me. So he was like, I'm going to rank Mayo first.
And this is at the same time you were applying for
No,
you were still a resident.
no, I was still a resident.
Yeah.
So he's like, I'm going to rank Mayo first. I'm like, go for it. You have to, like, it's the Mayo Clinic. And he matched there. So when I applied to Mayo, and I applied to Mayo. Mayo already had a separate program for critical care and pulmonary pulm crits. They had like separate just crit and combined pulm crit. So I applied Mayo. I applied the programs in Minneapolis. They had, like, Hennepin has a fantastic critical care program. I applied University of Minnesota pulm crit. I applied all the programs in Wisconsin, all the programs in Chicago, because they are driving distance to Roch, and Miami, because I personally think we should always apply and keep the doors open where doors were open for us.
Yeah.
So I applied in Miami, and I would have been happy to stay in Miami for pulm crit, separate from my husband, because again, like, had family, had friends who were family, so I was gonna be okay, I think, being still apart. We lived apart for a little bit over than a year. And it was not fun, and it was very expensive.
Especially Miami, Rochester.
Yeah, exactly. It was very expensive, but he's very happy. He's a hematologist, bone marrow transplantologist, and he does a lot of CAR T, like cell therapy. And he's the program director for the fellowship. So,
wow.
Yes. So I really don't think surgery was for him. But then again, when I went there, so then at that time, critical care was also outside the match. All critical care at that time was outside of the match. Is no longer the case. Everything is matched nowadays.
Yeah.
And they were like, hey, we know your husband is here. Do you want to just sign critical care? And then you know you're going to be together. I'm like, absolutely. Where do I sign? So I signed. And then I withdrew from the match. And then when they were like, oh, we want you to stay on staff, like after, like middle fellowship. But at Mayo Rochester, we don't have a department of critical care, so you will have to do pulmonary, so we can hire you through the Department of Medicine, Pulm Crit. And I'm like, okay, I'll take one for the team. And my husband still had a few years left, so I did Pulm, and then they kept me.
That's amazing.
Yeah.
That's an incredible story. I'm
Yeah.
so glad it worked out for both of you. So, to those of you who aren't familiar with this, so pulmonary and critical care are combined fellowships in the United States, 3 years, right?
Yeah,
Alice?
3 years combined. Mm-hmm.
And then some programs, not many, have a separate just critical care fellowship, usually 2 years.
Yeah, 2 years, because people can do that. Sorry to interrupt. People
No,
can do
please.
that through, like, you can do emergency medicine and do critical care as well. You can do neurology and do critical care.
You can do cardiology.
Cardiology and do critical care. So that's like usually, nowadays a lot of NEF critical care. We are
Really?
graduating a lot of NEF critical care. So that's why it's still worth having a standalone 2-year critical
Yeah.
care program, because people might want to do other things.
And then Alice was saying that she applied to both those programs, but the critical care one was outside the match, so you could get a direct offer. She got that direct offer, she took it, but then ultimately they wanted to hire her, so she completed her pulmonary fellowship as well. So she's now a pulmonary critical care attending at the Mayo Clinic.
Yes.
And associate program director for internal medicine. Let's talk about that. Let's talk about, I suppose that all starts with a passion for education, for medical education. To do the role of associate program director, where you're mentoring, you're giving feedback, you have this role of inspiring the residents, and also sort of like being a bad cop sometimes.
Yeah.
So let's talk about that. How did your journey in medical education evolve?
Very interesting you ask that, because remember when we first started, I wanted to be a trialist, right? Have
Yeah.
not done a single clinical trial. So I realized, actually in Miami, I'm going to be very honest with you, that I really enjoyed teaching people at bedside. And I love bedside. If you ask me, and again, like for people who don't know this, in the United States, it's very common for you to be a clinician educator or a clinician investigator or a clinician administrator. And the thing that I cannot live without in my professional side, my professional career is actually bedside critical care. So like, if one day someone tells me you can't be an APD anymore, you can't be, the only thing I'm going to be like, the only thing that gives me purpose, joy, and fills my cup, and to me is not work, is bedside critical care. But I found out that I was actually it gave me a lot of purpose and joy to show people at bedside what I knew. And in Brazil, we get very good at physical exam because we don't, like where I did residency in Brazil, we had one CT scanner, and if it was broken, you had to decide TPA or no TPA based on physical exam changes, you know, for like strokes, for example.
Yeah, I had a friend who also trained in residency in Brazil. You may know him because he trained in HEMONC and Mayo Clinic, Gustavo.
Yeah, yeah.
He was my chief in Miami, and he used to say, man, residency in Brazil is nothing like this. No. Like, it's just so much, like you get that hands-on experience. Even in Miami, which was a hands-on training program, but you had a CT scan like this.
You had everything. And I think Gustavo was actually my intern, right? Because he was 1 year ahead of you?
He was 2 years ahead of me, so probably.
Yeah. Great guy.
Yeah, I'm a huge fan.
Great guy. I think he's in Georgia. But anyway.
Yeah, in Georgia, HEMONC.
So I realized that I loved when people understood like physiological concepts because of things that I showed them at bedside. I loved seeing people, like hearing murmurs. I got really involved with University of Miami Medical School has the houses. No, that's not how they call it. Houses, yes. That the medical students are organized in like famous physicians' houses.
Okay, Hopkins does that. I didn't know that
Miami did. And back in my day, they had like a resident mentor, and I volunteered to be a resident mentor. Was Stacy Lieberman, who's now Ruben, in your class?
She was a year above me, I think.
Okay, so she was a med student, and I was like her resident mentor. And I just loved it. I just loved interacting with medical students and things like that. So then when I came to Mayo, I was like, you know what? I'm just going to teach these people at bedside. And if I can get one person excited about physical exam and critical care, it's fine with me. And like modeling and like all of the, point of care ultrasound and things like that. Yeah. And then my third year on staff, actually, was when I became eligible for this teaching award that the residents choose. And I was chosen that first year that I was eligible as the Teacher of the Year. We call the TOY Award. Wow. The TOY Award for the inpatient specialty. And again, like at Mayo Clinic, we're all specialty driven.
And everybody teaches.
And everybody teaches. So that to me, I was like, okay, this is a sign. But becoming an APD was never in like the horizon of my wildest, best dreams. And the way it happened was apparently the residents, beautiful thing about Mayo Clinic, one of the other magical things about Mayo Clinic is every leadership position at Mayo Clinic is a term limit.
Oh, really?
The day you start, you have 8 plus or minus 2 years to do your job.
Really?
It's beautiful.
I didn't know that.
It's gorgeous because then it gives opportunities to people like me. And so it was time for 2 of the APDs to rotate off. So the PD who took over that year calls me, and I had always been involved in interviewing for the residency. I've always been in the selection committee since I joined staff. So like first year they're like, "Do you want to join because the residents love you?" I'm like, "Sure, absolutely." And she calls me to her office, and I thought she was going to invite me to do the social media recruitment. Because the meeting subjects at recruitment. That's another very, very common thing in the United States for the people who are not from here. You get an Outlook invitation. You get like a calendar invitation for meetings. And
they just show up on your...
An agenda, and you just show up where you're supposed to go.
And there's a link or a location.
Or a location. And it's a recruitment. And I thought she was going to ask me to help differently with recruitment because I love social media. And I love teaching on social media. So I'm like, okay, that's what we're going to... So I came prepared with a pitch for like how to sell Mayo on social media because it was COVID, I think. Yeah, it was 2021. So we're like, how do we sell Mayo on social media? Because like people are not coming to our cornfield and seeing how awesome it is. And she's like, no, Alice, I'm recruiting you to be an APD.
It's recruitment of you.
Yeah, and I'm like, what? I need to think about this. I was not ready for this. So I asked for a few days to think about, because I was like, I was not ready. I was not ready, and it was not in my radar at all. I was very oblivious to that. And honestly, it's a great job.
I'm sure that when you took that position, it was on everyone's radar. They're like, oh, yeah, you're the perfect person for
Exactly.
that. We knew it all
People
along.
were like, oh, we always wanted you to be. I'm like, what are people talking about?
That's how it goes. It always goes like that.
What are people talking about? Yeah. So I love it. It's very fun.
That's amazing. Let's talk about congratulations, first of all. I'm sure you guys can imagine the magnitude of this, the importance of this, but it's hard to put it into words, just the importance of this position. This is the Mayo Clinic that we're talking about, Rochester campus, the main campus, associate program director of what is surely the largest residency program, internal medicine. So this is huge. Congratulations.
Thank you.
It's inspiring.
It's very fun.
Yeah.
It's very fun, and it's very heartwarming.
What does an APD do, an associate program director do? Can you explain it to me?
Yes, I can explain. It's a lot. Before I explain, I just want to make sure that people who enjoy teaching also remain excited and encouraged, even if it doesn't come with a title, because you don't need a title to care about your learners. You don't need a title to teach someone. 'Cause just think about this. If you teach someone else like a good physical exam pickup, or a good murmur pickup, or a good lab that doesn't make sense to that physiology, you are potentially helping that person save countless of lives. So being an educator is a self-given title. It doesn't need a fancy title. But being an APD comes with a lot of work. Great work. So our program, like you said, we have about 55 categorical residents a year, plus 12 preliminary. We don't have just preliminary usually. They are usually preliminary to neurology, anesthesiology, ophthalmology, and dermatology.
It's like a transitional year. If you're going to go into anesthesiology or neurology, first you do an year in internal medicine. We call them preliminary interns.
Yep, perfect. And each APD, we have 10 APDs. Each of us gets about 18 residents per year.
Like your pod.
Yeah, we call it a flock.
A flock, okay.
I call the Gallo family, but I'm okay with flock. And because they're all like my brothers and sisters. So then what I have to do, I have to meet with all of them quarterly to review their evaluations, to review how they are doing personally, to make sure that they are mentally safe, psychologically safe. At Mayo, our program, each of the APDs also has a specific role within the residency. My role is learning climate and belonging. So I need to make sure that the learning climate is inclusive to our learners, is inclusive for them to learn, and that they understand that they are there because we wanted them to be there and they deserve to be there.
Trying to get rid of that imposter syndrome,
Yes.
huh?
Because I'm going to be honest with you, I've been there for 12 years. And some days I walk in and I'm like, I see the Mayo Brothers statue and I'm like, these people made a mistake. pretty sure that they chose the wrong Alice, wrong Alice.
You guys can see, for those of you who've seen other episodes of MetaCast, it doesn't matter how high the position that the guest sitting over here next to me occupies. We've had now Alice, Associate Program Director at Mayo. We had Andre, who's Chief of Electrophysiology here in one of the Harvard hospitals. It's always like that. It happens to you, intern, and happens to Alice as well.
And it's very interesting. Like the Mayo Brothers statue is there, and it's supposed to be a reminder of excellence and it's just they chose the wrong Alice. I'm pretty sure something's not going to go right, and they're going to realize. But it's so I try to make sure that the learners in the internal medicine residency program do not feel that way. Does that make sense?
Yeah, absolutely.
And if there is someone who's struggling, then we also need to meet them more often. We need to create a learning plan. We need to make sure if they are struggling because of grades, for example, or they're not doing well knowledge-wise, then we create a plan. If they are not doing well soft skills-wise, then we give them resources to get better at that too. So, but we meet with them so frequently, so we can check on these things early on and frequently. So.
What's the hardest part of being an APD? It's uncommon that a resident doesn't do well,
Yeah.
but if it's a resident's not evolving well in terms of knowledge, as you said, is it giving feedback and getting that person back on track, or any other component of the job that is the toughest part?
I actually enjoy a good tough. I like crucial conversations, so that part is not hard.
Really?
I really like crucial conversations.
I have a hard time still, I gotta say.
I think it makes us all better. I think conscientious choice of words,
Yeah.
actionable examples. I think it makes us all better. Like the fact that I have to think about those crucial conversations always teaches me something too. So it might be selfish, but I really enjoy crucial conversations. I don't seek them, but I don't shy away from them. But I think the hard part has been so far the learners who really had a dream of Harvard, for example, and they ended up at their fourth choice, for example. That still is probably an awesome place. Yeah. And initially, like the initial shock of like not going to their first place again, we are all type A personalities. Right. I don't think any of us who made it to Harvard, to Mayo Clinic, to any place, to Miami, have a good understanding of what perceived failure is.
Right.
So it's very hard to show them that that's not a failure, that's a detour that might be great. I did not, when I did residency in Brazil, I really wanted to stay at my home institution at PUC. I really wanted to stay there. It was like home. And I had never not gotten A pluses. Like I had never my grades like were 90 plus forever, since like grade school, I think, whatever, baby. And I failed majorly the test for getting into PUC, and I ended up at Conceição. Best thing that ever happened to me. Loved that place. It was fantastic, great school. Some of my best friends that I call and talk every week are from there. So, but at that time, it was a blow to my ego, like no tomorrow. But now I understand that it was like the best thing that ever happened to me, you know? Yeah. The best thing that ever happened to me.
I recently learned about the competitiveness in numbers of applying for fellowship for cardiology at Brigham, for example. Mm-hmm. It's more than 100 applicants per position. Mm-hmm. So not everyone's going to match on their number one choice. There's just no way.
But for us, it's easier to see. Yeah. If you're in the eye of the hurricane, if you are the applicant, I think it's harder.
Yeah.
And so the hardest thing, I made it a very convoluted answer, I'm so sorry. The hardest thing is to stay mindful that, like, don't forget what being in the eye of the hurricane was like.
Yeah.
Again, like I had a lot at stakes. Like I had a geographical constraint that I was not willing to like overlook, you know, when I applied for fellowship. So I try to be mindful of that, whatever reason people have.
I want to pick your brain about the application process for residency.
Yeah, I love that.
For fellowship, and especially with your eyes as an associate program director and sitting on this other side of the selection, not as an applicant, but as someone who gets to decide.
Yeah.
But before I do that, I just want to make a quick comment on the role of education. You were saying about that you don't need a title to teach. And I just want to add a little bit about my own story.
Yeah.
Because I've always loved to teach. Ever since I was in medical school, I used to be a tutor. You know how we have monitor in Portuguese. And I used to be a tutor for anatomy and then biochemistry and this and that. And when I joined the residency in the United States, when I came to Miami, something that really amazed me is that how much people value that here. someone's always looking. You don't have to have a title, but your associate program directors, your chiefs, your PD, people are going to take note. I'm not saying that you should do it for that reason, of course. There needs to be a genuine interest, but I always love to do that. And as an intern, I wasn't aware of this, but like it quickly got around the word of mouth that like I did this. I won Intern of the Year award. I then became chief. I used to teach basically at every situation, and this really, this gave me a lot in return. A lot in return. My program director was a huge advocate for me when I applied for fellowship. It's one of the things that was highlighted in my letters of recommendations. Ultimately, this led me to create this platform for teaching. So if you guys have that skill or that desire to teach, if you come to the United States, you will be valued for it. I think it's a little bit different in that sense from Brazil or other places potentially, where you will, of course, get some credit for it. But over here, people will really cherish that.
Yeah. And again, it was not even in my wildest, bestest dream. It was... People noticed.
Yeah, people noticed.
People noticed.
Yeah.
And it's genuine. And I again, I've seen you teaching a lot, and I think when you do it from the heart, people just see it, like everything, right? Yeah. I learn a lot from you. I love this podcast, actually. I listen to it a lot. And everybody has imposter syndrome. It's really, now that you said it, it's like, I shouldn't be here. Yeah, you should. Yeah, you should.
You deserve it.
You deserve it.
You worked hard for it.
Yeah.
So Alice, tell us a little bit about the application process for internal medicine resident at Mayo.
Yeah.
What makes a super strong resident or an applicant? And I know this is a broad question, but I want to get your answer to that broad question.
One of the things I'm very proud of in our selection committee is we review everyone's application.
No filters?
We have 2 filters. We have not having a felony. So if you had a felony, you're excluded. And we decided that our program is excellent enough that we can filter failed steps. So those are the things we have. And for foreign grads, we do have a filter for clerkship. Reason for that is, and I understand observerships are easier to get. Observerships can be done after people graduate. We understand all of that, but all the concerns that were raised about foreign residents, foreign medical grads, were when we took observers and English was not as good, or they didn't go through that exercise of like presenting at an academic institution and know what to say on rounds, or even like how to ask patients things. And we honestly, which is very sad, we noticed this after CS was
removed,
deleted, I don't know, but canceled, because CS made us study the cases and made us study the way we are supposed to talk to people. I don't know if you did the same thing, but I had my husband being my standardized patient, and that was his standardized patient.
I had some Indian friends in Miami. Step 2, clinical skills. A lot of them won't even know what it is anymore.
They don't know what it is, exactly. But I believe that was very helpful for us, that English is not our first language. So I think, and so that's when we decided, because we had to really remediate some residents who struggled talking to patients, and patients raised concerns. They're like, I don't think they understand what I'm saying. So that's why we have a filter for failed step and clerkship.
I want to just make a very quick comment on that, because I did, in my own journey, I did an observership in Miami, 2 months. I got great letters. You know what the observership in Miami is like. You really get to do quite a bit, and you get to leave a good impression. And I always tell people that if you can't do a clerkship, whether it's because it's financial reasons, you haven't graduated yet, or because you already graduated and you don't have a chance to do a clerkship, you don't let that be you shouldn't, let that put you down or think that you won't be able to match. You absolutely will be able to match. There are some programs like Mayo Clinic that will have filters, but you have to also understand that it's an exception. Most programs will give
Yeah.
you. Most programs will mostly care about what you did, whether as a clerkship or observership, and what's reflected in your letters of recommendation.
Yeah, and again, we read all the letters. So if people have a letter, we have like made exceptions when people had letters that were so strong and clinically strong and things like that with observerships. But again, we read everything, but we do filter.
Okay.
But then it's like, oh, Brandy sent me an email about this person who observed with him. That always helps. So again, like if you have networking and if you have people who can vouch for you, always a good way of overcoming filters and red flags. So
Yeah, that's good. And what are the most important components of that application? You pass all the filters, you've passed the tests, you've had the clerkship, or really, what's between steps, research, and volunteer work and personal statement? What are the most important components that you see there?
the storytelling. We want to make sure that we are recruiting good humans. They're gonna hold the Mayo values. We love diversity. We love diversity.
Gaúcho.
Yeah, exactly. We love diversity, and we're not looking for a specific skill. We don't have this thing like, oh, you have to have 10 papers. No, if your story is about being a good educator, if your story is about being a good educator, we want to see that you were teacher's assistant for anatomy and histology and physiology and all of those things. If your story is more of service, we want to see that your volunteer experience made sense. Yeah. And we want to make sure that your personal statement, we love personal statements that are actually personal. So like, what made you you? What road did you have to take from Porto Alegre to the middle of the cornfield of Rochester, Minnesota? So we want to hear a story. We want to read a story. And we do look for people, I think, applicants in general underestimate a selection committee, because we look like hawks for any signs of potential flight risk. So we have a lot of applicants that we can tell that internal medicine is their backup.
Really?
Oh yeah. So if
How can you tell?
Oh,
spill the secret.
Oh yeah, I'm going to. You heard it here first. So like, if letters don't say what specialty they are applying for, like Dr. Gallo will be a great asset for your program, not for your internal medicine program.
Oh.
We read people's medical school transcripts, so we very often find people who did all their clerkships, electives, everything in neurosurgery, and then they're applying to internal medicine. So people underestimate selection committees, I would say. So we look for that too, because again, like for people to understand, for a program to lose a resident that was ranked categorical, it does affect the program in terms of scheduling for the following year and things like that. So that's why we look for these people even before we call them for interview.
So essentially what Alice is saying is that programs don't like when their list goes too further down. Like if you...
No, meaning like, for example, let's say this person neurosurgery ends up like matching into our internal medicine program and then leave.
Oh, I see.
So we like when we are selecting.
It's not just about ranking, because I was going to ask you why when I said that, because I never understood like what's the problem with the list going further down. Everyone's supposed to rank whoever it is that you want, where you want to match, and programs are supposed to match their applicants. So good. So that's not the problem. It's the person matching and then going somewhere else.
Yes.
Oh yeah. That's not good.
Because then people do a year and then they reapply. Yeah. And then we don't have someone for second year, and that really messes up programs, all programs. So it's not just Mayo.
I love what you said about storytelling. When people ask me about what's the most important thing on an interview, that's usually the answer I give. And my definition that I really like about storytelling is when your past connects with your future. Whatever you say that you want to do for your career, and obviously that should be real, that should be genuine, that should be what you really want to do. it's good that you have the track record for that. And if you're in an interview setting where it's just not a CV or a personal statement, you have to be able to articulate that well.
Yeah, absolutely. And again, like your CV should tell the story of you, should tell the story of like how amazing you are, or and now with this thing like it's not impactful experience. It's okay if you had a super boring childhood like mine. Like I had a super boring childhood. I have no traumas. I'm like super happy. That's okay. But I want to hear like what gives you joy? What gives you purpose? What makes you wake up at night in like 5 a.m. and go to work happy, you know?
Yeah. Yeah.
So that's what we want to hear. We want, at least I can speak about, and again, this is my opinion. We are looking for people who are going to be fun to work with at 3 a.m. when an ICU is on fire with 3 new septic shock, patients.
And what about the scores in all of this? Well, I guess now it's not scores because now step 1 is pass fail, then you have step 2. Once you've passed those filters, let's say you do have a very compelling story to tell. You're, for example, an educator. You've been tutored, done this, done that. You communicate in an interview that you want to do teaching as a career. Is there a point where you or Mayo or you think potentially other really elite programs will say, this might be a good applicant otherwise, but the scores are just too low?
No. Because for us, and actually this data comes from Mayo, we looked into this several years ago, not me personally, but my colleagues, that failing a board exam is directly correlated with failing your specialty boards. So that's why we use just having failed once. We have had people we interviewed with scores as low as like just barely passing, like 228.
Really?
And I did very poorly on step 1, by the way. I just want to make sure that I tell this to people. Because again, 10 out of 10 do not recommend. I took all the steps in 8 months, do not recommend. So I did very poorly on step 1, and nowadays it's a badge of honor. It was a huge struggle for me because again, like I had never done poorly in tests. But in the residency program, I wanted it back home and step 1 because I was cocky for step 1. I was like, I can do this. It's gonna be fine. Blech. Back in my day, it was 2-digit score.
Yeah.
And for you to be successful as an IMG, you had to have 99 and 99. And I got 99 in step 2, but I got 87, I think, in step 1. And that was like, end of me. But hey, look at me.
You are APD at Mayo Clinic. I always tell people, of course, that if you haven't taken the steps, of course, you should aim to get a high score.
Yeah.
Obviously, that's intuitive.
Yeah.
And especially because it's one of the few components of the process where you absolutely have control. Mm-hmm. You may not have control about the fact that you can't do a clerkship at Mayo Clinic, but in the steps, you can just sit and study and prepare yourself. Maybe not do it in 8 months, everything together.
Don't do that.
So I definitely recommend people aim to have a high score. But I think what this story that Alice is telling us really means is that, like, if that's not your case, you, for whatever reason, personal, professional, or you just couldn't get the 99 back then, now like I choose 70 on step 2, you don't forget that the component, that the application is multifactorial. Yes. There are multiple other components there in the application.
And to be honest with you, like nowadays we are using steps more, like scores more to like both people, like 2 people with a very similar application. Very similar. Huh?
Tiebreaker?
Yeah, tiebreaker. Oh. Very similar application. And one got like 276 and the other one got 230. We're probably going to call it 276, but still, we still read both of them. Both of them still had a shot. And we try also to be very mindful. We don't want only clinician educators. We want the researchers. We want the clinician educators. We want the service, the servant leaders. So we try also to do kind of like, okay, we already called too many clinician educators, So
yeah, very good.
Yeah.
Excellent. Alice, before we wrap up, we only have a few minutes.
I'm having too much fun.
I feel like we could, like, there's so much I could learn from you and the listeners, of course. Amazing. It's going to be great. We have to do schedule around you. But can you share a little bit about your insights of critical care as a specialty? It's unique that it's combined like it is in the United States, pulmonary mostly outpatient, critical care, inpatient, and nights and days and all of that. What's it like?
I love it. But again, I'm super biased, totally biased. I absolutely love my job. I love my job that to the point that if my taste was not so expensive, I would do critical care for free. But I like a lot of expensive things in life. So yeah, I love my job. So what I love about my job is that there's never a dull moment. And I realized, I contemplated just being a not doing a fellowship and staying as a hospitalist because I really enjoy wards and I really enjoy internal medicine. I do love the fact that critical care is internal medicine on steroids. I just love it. Like I have to know everything, and I love it. But I realized that if someone was there for like 8-9 days, I would get a little restless. I'm like, why? Why are you still here? So I was like, okay, I need to do critical care, I think. So that's one of the things, like high turnover. And what I love the most, if you have a day when you admit 3 patients with diabetes and DKA, they're not the same. The 3, like they might be next to each other in the ICU, but one has end-stage renal disease, so you have to be super careful with the electrolyte shift change. The other one is like first time having DKA from this brand new diagnosis. And then the other one is now on immune checkpoint inhibitor for their cancer, and their pancreas now has pancreatitis from the ICI, So it's never a dull moment. And I do a little bit of pulmonary because Mayo Clinic does not have a full department of critical care, and I do pleural diseases, and it's super fun too. I get to do thoracentesis, pleural catheters, think about the pleura. The pleura is a fascinating organ, and I love the patient relationships. I do love my patients. I kept all my patients from fellowship. So at Mayo, that's one of my favorite things about fellowship at Mayo Clinic is you don't go to your attending clinic. You have yours. There's always one of us there in the afternoon that's who you're going to staff your patients with. So we have to stay pretty good general pulmonologists. But when I stayed, I was like, okay, I'm going to keep all my people. So I still see like all my patients with bronchiectasis, with ILD, all the things, because I kept them all. And I love the relationships. I love the longitudinal relationships, which is something you don't get in critical care. But one of the reasons also why I love critical care is that patients don't get to choose me. So to me, that's like an extra motivation to be dedicated and excellent. It's like it's why I dedicate 35, 45 minutes every day to study something, because they don't get to choose me. Yeah. They get me. So I need to be the best because they are someone's mom, they are someone's sibling. So I think that's what keeps me motivated. And then for the rest of my time, I do what we call at Mayo administrative time, educational time, which is at Mayo we are salaried. So it's not our. I'm sorry for the people who are not here. So like there are 2 different systems of paying physicians in the United States. You either get a salary or you do RVUs.
Which is productivity.
Yeah, productivity, yes. So we are salaried, so we don't get more money for doing these jobs. We just get protected time. And not just, is a huge deal. And I get about 30% for my APD role and for being in charge of our rapid and cold teams. So,
nice.
Yeah.
We do need to set up a round 2. We're out of time, but there's so much more. I do have one final question that I can't let you leave without asking you this. What makes a resident stand out? Because I get this question all the time. You have all this experience in teaching and as an associate program director. What makes a resident become a star? It makes you pick up the phone and try to call someone to help this person match into fellowship in their specialty?
It's the things you cannot teach. It's their heart. You got to care. We can't teach people to care. You can teach EKG to anyone, right? You cannot teach people to care enough to stop, be present, and look at that EKG. Yeah. And look at that human in front of them. Yeah. So in my opinion, is the people with soft skills, with a huge heart, with you don't have to be positive like me. It's not I'm saying, but like a good attitude, yes, and, or if it's no, is no and, not like no. It's like no, and I want to recommend so and so, you know?
Yeah.
So is to me, that's my opinion, is the things you cannot teach. I will always make a phone call for someone who I know cares about their patients like they care about their parents. And you can't teach that. So it's the things you can't teach. Just gotta care.
Yeah, I have nothing to add to that. That's just a beautiful answer. Just amazing. Alice, this was incredible. It's such an honor to meet you in person, to have you here, to learn from your experience. I learned a lot. I'm sure our listeners did. Congratulations to you and your journey so far. So junior still in your career, you've done extraordinarily well. You are an inspiration to all of us. Congratulations.
You are an inspiration. I'm very honored that you got me here, and it's amazing to me that we had never met in person.
I know.
But I'm a big fan. I'm a big fan. I want to be like you when I grow up.
Likewise. I went through Miami hearing about the stories of some Brazilians who left a positive mark there. You were one of them, So, yeah, very good. Guys, so this was one more episode of MetaCast, the podcast of the Meta-Analysis Academy. I forgot to say this in the beginning, but the Meta-Analysis Academy is a program where I teach you how to do systematic reviews and meta-analysis, high-impact research with autonomy. I always give a disclaimer that I do not do research projects for you guys. I teach you how to do it. I'll give you all the methods, statistics, and writing tools for you to do well. Our students have been incredibly successful, and I invite you to follow us also on Instagram, to join our wait list, to participate in the next edition of the Meta-Analysis Academy. Listen to MetaCast with other superstars like Alice herself and others that have come by. So if you speak Portuguese, we also have a Portuguese version. So there's so much for you to benefit from our team here. And I want to thank you for listening, and I want to thank Alice, Dr. Gallo, for participating here today.
Thank you for having me. This was a blast.
It was a lot of fun.